Welcome to Healthbeat, the show that takes the pulse of South Africa's healthcare system. I'm Mia Malan. This month, we're at the Diepkloof Forensic Pathology Service in Soweto, where the living come to identify their dead. But some bodies are never claimed. Some are too young to even have names. These are the babies found in dustbins, dumps and ditches, abandoned every year in South Africa. In this episode, we're looking at the reasons behind such abandonment and how to address them. When a woman abandons her newborn or is left with a fetus after an unsafe abortion, it often means she had no other choice. Every tiny body that arrives here proves how hard life can be for mothers and highlights the barriers to healthcare. The academic work at the mortuary is led by Shakira Holland, who has a joint post with Wits University. Shakira, thanks for your time. Do we really know how many babies get abandoned in South Africa each year?
We don't have accurate statistics about this because there is no digital database of unnatural deaths in the whole of South Africa. What we do know is we have approximately 70,000 unnatural deaths in South Africa, and of those we estimate that approximately 2% would be abandoned neonates and fetuses.
So those would be fetuses, dead babies, right?
Correct, that's correct.
So you supervised the study here in Diepkloof, Soweto at the mortuary, and you looked at where do fetuses, for instance, come from? Where do you find the bodies most commonly?
Majority of the time, the remains are left where it is convenient and probably where people think they won't be found easily. So open velds and landfills and dump areas. We've also found that there are some that are not the majority, that are actually found in places like shopping centres, toilets and places, other public toilets as well.
If you look at the sex of the babies that you find, is there a difference between girls and boys?
So most of the fetuses in our study were male.
Have you got any reason why that could be?
Most of our pediatric deaths happen to be more boys than girls, and this goes with international studies as well.
What do your autopsies show? What are the causes of death?
So the commonest cause that we see are non-viable fetuses. This means that the fetuses haven't completed sufficient time in the pregnancy for them to be surviving independently outside of the mother. So that is the majority of the causes of death that we see. We also see a lot of stillbirths. So these are babies that have completed enough gestational time in the mom to be considered viable, but then are born deceased. Minority of the causes we do see are trauma, and that can either be accidental or homicidal in very few cases.
What are the most common causes of the trauma?
A lot of the common causes are head injuries, and a few are related to suffocation. And we've maybe had one or two where there's sharp force injuries. So, for example, the fetuses or neonates' necks have been cut.
Why did you do the study?
We see these cases of abandoned neonates and fetuses every day. And I mean, we see these newspaper reports about these cases, and it seems as if they never happen, but in fact they are happening every single day. So I had a student that was particularly passionate about the topic and wanted to look at what is exactly going on in this area and hopefully spark research in other places, because we don't know much about it.
So when a fetus gets here, what happens to it?
They undergo a medico-legal post-mortem examination, which includes an autopsy. That autopsy includes taking any investigations that are necessary to determine the cause and circumstances of death. Once that is completed, we compile a post-mortem report. And that report would then go to the South African Police Service for further investigation, for them to decide whether or not there needs to be prosecution in this case.
And what would happen to the remains?
In fetuses that are less than 26 weeks, they are discarded as medical waste. In neonates of 26 weeks and older, they are buried as paupers if nobody claims the remains. So when I say paupers, it's basically to say that the state would assume the cost of the burial.
Do you have enough doctors to conduct these autopsies?
At present, our doctors are doing anything from 500 to 600 postmortems per doctor per year. The ideal amount would be about 250, because we need to take into cognizance that the process is not just doing autopsies. In fact, it's the holistic perspective of what happens here is that the doctor has to do the autopsy, then compile a meticulous report that needs to stand up in court.
We have more than 1,000 unemployed doctors in this country. Why can't you use them?
We do not have enough funded posts for doctors, even though we do have a lot of doctors who would like to come and work in our service.
Have you got a specific policy intervention you'd like to see?
That's exactly why we do these studies, because we're hoping that if we are able to shine a light on where the problems lie, we are able to give a basis for policy development to say that this is where intervention is necessary. I think it's very sad in that the law actually provides for women as young as the age of 12 to get access to contraception without parental consent if the child has a clear understanding of the process. And I feel like perhaps girls do not know about it, they do not know enough about it, or they are not getting safe access to the service. And the same with termination of pregnancy. So it's a lack of knowledge perhaps, or perhaps it's a lack of access for these young women.
Shakira Holland, thanks very much for your time.
You're welcome.
After the break, why so many young women are unable to make safer choices.
There are still many administrative barriers. You need to have a proof of address, you need an ID, you need a whole lot of other co-payments in some facilities that people are not simply prepared for.
It's been nearly 30 years since President Nelson Mandela signed the Choice on Termination of Pregnancy Act into law. It's intended to make abortion safe and accessible. Research shows that many government clinics that are supposed to offer abortions don't have the staff to do so. This creates long waiting lists, forcing women who want an abortion early in pregnancy to wait until much later. But in private clinics, abortions are much easier to get, if you can afford them. One of the first private abortion clinics in South Africa was started by Professor Elna McIntosh in the 1990s.
Good afternoon.
Elna McIntosh was barely out of school in the 80s when a failed contraceptive loop and unintended pregnancy had her scrambling.
So I fell pregnant between Christmas and New Year, and I'm thinking I'm so safe because the family planning nurse put a loop in. So I've often thought about that. Would I have had an abortion? Hell yes, but it wasn't legal. I know what it's like to pee on the stick and know your world's going to end now.
When she trained as a nurse, she saw what happened to women forced to go the illegal route.
In the 90s, we worked in hospitals, we worked in emergency rooms, and we see the botched, the bled out woman, which was tragic as well. But sadly, this is happening again today.
Post-1996, health facilities began providing abortions for all. Elna ran the DISA clinic with a purpose.
We wanted to have a place where women could go where they're not stigmatized, because often if they were done in hospitals, people would also go, oh, that ward, or those nurses working there. So that's what happened. Nurses wouldn't want to work there anymore because their church is not happy with them, or their family isn't happy with them, or people are calling them names.
Today, she's still providing safe abortions.
I think once an activist, always an activist.
She thinks many pregnancies and young people can be prevented with access to the right advice. But they often get the wrong advice from social media.
Are you on birth control?
No. Pull and pray.
Same. Are you on birth control?
No. Pull and pray.
Same.
So the cycle for me usually goes October, November, the kids start writing exams, and then matric dances, then rage comes and they all go on holiday. And so most of them will discover they're pregnant by Christmas, and now January comes and now they may be already 2-3 months pregnant, but now they have applied at university and they're going to wherever they're going. Some of them would go, and nowadays with cell phones, with TikTok, Google, that would be their first port of call.
Almost 7 out of 10 unplanned pregnancies end in an abortion in middle-income countries like South Africa. If medical treatment is out of reach, women are on their own. Abortion is a safe procedure when the correct methods are used. Yet, worldwide, 45% of all abortions are unsafe, often because they happen in secret without proper supervision. Some turn to fake clinics and dangerous pills, even in South Africa, where abortion is legal. This is often because of stigma or because people don't know that legal clinics exist. Elna counseled a woman who had been misled by a dodgy clinic in Sandton.
So she went there and they told her she's 26 weeks pregnant, but they offered her a termination. It's all right, we're going to sort everything out, okay? Don't cry. But she then wanted a second opinion. So when she came here, she was 31 weeks pregnant.
The woman ended up going on to have the baby as she was already in her 3rd trimester. But women don't always end up at safe clinics. They're frequently at the mercy of scammers trying to sell them non-existent meds like Sona pills.
My best always is the Sonar pills. You see, abortion, this, and Sonar pills. Now, you can't do a Sonar with a pill. It's not like the pill is going to go and then it's going to look around. But people say, I must have a Sonar. Yana, we're giving you the Sonar pills. And womb cleaning. We give you the pills and womb cleaning.
DISA's medical director is Tlaleng Mofokeng. She started here as a community service doctor and now fights for women's rights globally.
Dr. Tlaleng Mofokeng is the United Nations Special Rapporteur on the Right to Health, and she's also a medical doctor in South Africa who specializes in reproductive health. She joins me online via Zoom. Tlaleng, abortion is legal in South Africa, and in a government hospital you can get a free one. Are these abortions accessible enough?
Not entirely, especially when you look at the systemic and structural barriers that continue to exist despite a legal framework that is enabling. In this case of South Africa, the structural barriers speak a lot to underlying determinants of health. There's a lot of delays in getting people to the hospitals because to even get a diagnosis of a pregnancy, you require to then be referred most often to another facility where you can then get the process done. So that the delays in the weeks and then the gestation keeps growing, it means a lot of people actually also then end up in a 2nd trimester abortion, and not of their own doing, but because of the poor referral networks. The other important thing is that, women are working. We are in the informal economy. We have jobs that don't have labor protection. And so to take time off to attend to a clinic repeatedly where you are also met with stigma, it means that your chances of going back to those clinics are very low.
So how does this play out in practice at a government hospital?
There are still many administrative barriers. You need to have a proof of address, you need an ID, you need a whole lot of other co-payments in some facilities that people are not simply prepared for. When they are dealing with a health worker who is anti-choice, suddenly, even if she had a headache, even if she had a toothache, everything now becomes about the fact that she had an abortion, and the stigma and the discrimination starts. And that's why illegal, unregistered, and unsafe providers are proliferating even on social media, because they're taking advantage of that vulnerability that's created by the system.
What kind of waiting periods are women looking at government hospitals?
It's really the luck of the draw. For example, the medical abortion for those who are 10 weeks and below, very, very good and very, very successful as a program and how to manage. And that, Mia, can happen on the very day that you present. I've seen people who have self-tested pregnancy, definitely within the 6-8 week period, and they'll only get their termination at 18 weeks because of the delays. You have others who are able to do it within 2 weeks. Others are able to do it within 4 weeks. And that's part of the problem. When you don't know the kind of quality you are going to get, and there's no standardization.
Sometimes we see stories in the media in South Africa where a doctor would say for a second trimester abortion, just give the pills.
There ought to be consequences for that. But we have normalized it so much in South Africa because we are making a moral judgment out of what is a clinical decision and an autonomous decision that should be made between a provider and a patient. And so for me, I think one of the biggest lessons is that those people are allowed to practice with impunity, but everyone knows where they are. If you go to Gandhi Square now in Johannesburg, everyone knows who's selling the pills. And so the question is, why is there no political will to actually fix this problem? Of course, it's gendered because it affects those who can get pregnant, but it's also about putting people deeper into poverty. Some people will, unfortunately, have carried a fetus that has abnormalities because of that medication that was given at the wrong time, in the wrong way, in the wrong quantity, and even mixed with other things that are not even abortion pills.
Tlaleng, you as a medical doctor have counseled numerous women who wanted abortions and helped them successfully to terminate their pregnancies. What are the reasons and who are the clients that come mostly?
Many of our patients are married couples who had wanted a pregnancy. Some people have gone through tremendous challenges with intravenous fertilization, and something happens in their relationship and they are getting divorced, right? Or someone just suddenly loses their jobs and their socioeconomic status immediately changes and puts them in a crisis. Some people are young people who are in high school and they need to continue and have their right to education protected. And that's what safe abortions do. Women feel so much relief after you have helped them get an abortion.
Tlaleng, to end with, what happens if you make abortions illegal in a country? Do you have fewer abortions or do you just have more unsafe abortions?
Criminalizing abortion, making it illegal, actually does not make the need for abortion go away. You are just pushing people further to the margins and they will have no access to redress or accountability. And that in itself is a violation of the right to health.
Dr. Tlaleng Mofokeng, thanks very much for your time today amidst a very busy schedule.
Thank you very much. Anytime.
After the break, what a real solution might look like.
We are trying to make them our ambassadors to also spread and make it fashionable not to be pregnant.
Experts say it's a reproductive health crisis. Abandoned babies and incomplete and unsafe abortions lead to tragic outcomes, even though termination has been legal for decades. Our team met Professor Zozo Nene, a reproductive health specialist at Steve Biko Academic Hospital in Tshwane. She's leading a project tackling teenage pregnancies, one province at a time.
Every day in our country, 365 teens give birth. 10 of them are under 15. Some arrive at hospitals like Steve Biko Academic in Tshwane, having hidden their pregnancies for as long as possible and are unprepared for what's coming.
So last year we had to deliver a 13-year-old in our own labor wards. And that 13-year-old refused vaginal examinations, which we know you need to have them done to progress labor, to check how far is labor and so forth. And so when someone is going to deliver, they know from antenatal care they are supposed to be told about these things, that they will have vaginal examinations. So she refuses the vaginal examination, so nobody is able to progress the labor and know what is going on with the labor. And then she's refusing the monitoring of the baby. So now we don't know how the baby is doing. There's a disconnect. They don't understand that now I'm pregnant and this is going to happen to my body, this is going to happen to me at delivery, and this is going to happen to me after the delivery. You have to understand the development of a young girl and the fact that now puberty happens much earlier on than we expected. So it can happen at the age of 8 years old. But at that time, the brain has not developed well enough to understand the what we call the cognitive part of the brain, is not so well understood by the young person to appreciate sort of cause and effect. So while they are trying to understand their own development, this puberty, development of breast, the starting of the menstruation early, and you can imagine for an 8-year-old that must be very uncomfortable. Even for the parents of the 8-year-old, it's actually very uncomfortable. So now they engage in sexual intercourse for whatever reason, and they didn't know that was going to result in a pregnancy. So now they're falling pregnant. So the body changes with pregnancy, and so now they're trying to understand that. They must go to antenatal clinic. They are so scared.
Nene and her team have raised money from private sponsors to travel to different provinces to train nurses, doctors and teachers in dealing with teen pregnancies.
The outreaches have been very insightful in the sense that they've given us a bird's eye view into what happens to the teenagers, how they feel about the system and what we are providing for them. And what they have said is that they have this information, but not from the correct sources. They have it from social media, they have it from, their friends, and they watch TV, which means we are missing the boat if we think we are going to only start the comprehensive sexual education at grade 7 or grade 8. Then they've mentioned the issue of respectful care. So what we are teaching in this outreach is respectful care, is counseling, trying to talk to them in their own language.
The younger a girl is when she falls pregnant, the harder it is to get help.
Are there enough clinics? Are they available when the kids are out of school? Because there is no point for a clinic to be opened from 9 to 4 o'clock. They are at school, So by the time they are out of school or on weekends, then the clinics are closed. So are we saying that they should skip school to go and access the service? But I have proposed to both the Department of Education and Health to say, why can't we have the services inside the school?
Nene's training is on how to give girls science-based, non-judgmental help.
We are engaging with religious leaders. They are also worried about teenage pregnancy, and they realize that we cannot, keep on burying our heads in the sand and say, don't have sex and don't do this and be judgmental.
No to teenage pregnancy. Viva Northern Cape, viva! Viva Northern Cape, viva!
Being judgmental plays quite a big role in being a barrier to accessing the service. I've said that social media, yes, it has its negatives, but we can turn it into a positive. Yeah, if we have to give them free Wi-Fi, right? And then throw in some adverts. I know on my phone there's adverts that pop up all the time that I don't want. So we can use it to our benefit. If we're saying the kids are going to parties, go and put in the flyers, the messaging, the condoms, whatever it is. So we need to find a way of making that work to our advantage.
For Nene, success will be measured by the numbers when teen births drop.
If we go to one area, we call as many as possible from that region. So it's about cascading the training, and they've said that after this, we're not the same. Things have changed for us, so we are trying to make them our ambassadors to also spread and make it fashionable not to be pregnant.
That's our show. If you have a story or a tip-off, reach out to us on health@bikisisa.org.